Hi there, this is the webinar administration team. We're ready for the slides to be shared, please.
Good afternoon, good evening, or good morning, depending where in the world you are. Welcome to what is the 5th session of our webinar series on rehabilitation in conflict. This time we're being supported by the International Society of Prosthetics and Orthotics, or ISPO, and we're covering the topic of amputation in conflict and key considerations. Thank you all for joining. I'm sure many people joining after a long, hard day at work. Great to have you all with us wherever in the world you are. Next slide, please. My job today is just to run through the administration. So first of all, languages. We're very lucky to have 2 volunteer Arabic interpreters with us today. To listen to the Arabic interpretation, please click the 3 dots at the bottom right of your screen. Select the globe icon for interpretation and choose the option Arabic. If you prefer not to hear the English audio in the background, you can click the globe icon for interpretation again and enable mute original audio. We'll now enable interpretation, after which you can follow those steps. If you would like other languages, we have caption-based translation available, including in Persian, Farsi, and other languages. However, we can't take any responsibility for the translation quality as it's done via the built-in AI in Zoom. And the instructions for that are on the right side. Next slide, please. That's back one. So we follow our usual format. So each webinar will be an approximately 1-hour presentation, and we have plenty of time for discussion afterwards. We have disabled questions from participants. So if you do have a question, please don't raise your hand during the session, but use the Q&A function. The Q&A function may appear hidden. You access it by clicking More, which is the 3 dots, and then you have the option for Q&A comes up. And please do put any questions at all for the presenters there, and we will make sure that they're answered as we proceed. For any general comments, greetings, if you want to put your name and your location in the chat, please do so. And we also welcome feedback. The webinar is being recorded. A recording and transcript will be made available on the World Physiotherapy website shortly after the session. If we do approach over 1,000 attendees, then we will also use YouTube Live. So for those people not requiring interpreting, you can switch to YouTube Live, and the link is now in the chat. If you do have any technical issues during the webinar, please just try refreshing your browser and then rejoining the session. If you're not able to rejoin, you can again switch to YouTube. Finally, and this is an important point, we ask for all participants to engage respectfully and professionally in the chat and the Q&A. Help us create a positive and inclusive environment for everyone. These webinars are focused on sharing of knowledge. We're doing this at a time of conflict around the world, and we may have people participating with different views and different politics. These webinars are open to everybody and should be kept free from political, religious, or military opinions. We're sharing knowledge to help improve patient care during what is a difficult time around the world. I thank you all for your participation. The agenda for this evening will begin with opening remarks from Sandra Ramdial, who is the president of ISPO. We'll have an introduction to amputation and conflict. We'll discuss the adapted clinical management of amputees. We'll cover the common complications, challenges, and adapted rehabilitation practices, important considerations and key points, and then we will have plenty of time for questions and discussion. So without further ado, it is my great pleasure to hand over to Sandra Ramdial from ISPO. Thank you again, Sandra, to you and all of ISPO for your support in arranging this webinar. It's great to have you and the team on board. Over to you to walk us through the rest of the evening. Thank you very much.
Thank you for the kind introduction, Pete. It's really a pleasure to be here. And hello, everyone, wherever you're joining from. It's great to have you with us. So just to add a quick note, I come to this not only as ISPO president, but also as a certified prosthetist in Canada with over 35 years in the field. So this is something I care deeply about. And for today's topic, it's especially important that this early care includes all those working in orthotics and prosthetics from the very beginning. Amputation in conflict settings, must be recognized not only as an emergency surgical intervention, but as the beginning of a lifelong health condition that requires a coordinated system-level response. When that happens early and when it happens together, the outcomes can be completely different. So at its core, this is about people working together. Next slide, please. It's the interdisciplinary team: surgeons, therapists, prosthetists and orthotists, nurses, mental health and psychosocial support providers, and all those involved in rehabilitation, coming together around one person, not just treating an injury, but understanding a life, their environment, their daily realities, their goals. When that kind of coordination happens, you don't just see recovery, you see possibility. But we also know it's not always straightforward. In many settings, early rehabilitation is challenged by things beyond the clinic: policies that create delays, supply chains that don't reach where they're needed, equipment that simply isn't available at the right time. So these barriers are real and they directly affect outcomes, which is why collaboration and coordination at every level are so important. Not just what we can do today, but what continues tomorrow and beyond. So at ISPO, this is central to our work. Across prosthetic and orthotic, mobility, and assistive technologies, we focus on strengthening the full continuum of care, from those early moments through to customized treatment and care and lifelong rehabilitation. So if you haven't already, I'd encourage you to visit the ISPO website to learn more. We've made it a priority to keep membership accessible, including very low fees for our colleagues in developing countries, because this is a global community and everyone should be part of it. So looking ahead, we're organizing our next World Congress in Thailand in May 2027, and I truly hope to see many of you there and connect in person. And now on to our partnership with WHO. This is grounded in a shared belief that prosthetic and orthotic services are not optional in emergencies. They are essential. Essential for recovery, for independence, for participation, for function, and quality of life. So it's essential that care is person-centered, evidence-informed, and delivered within a continuum of care, from acute management through rehabilitation to prosthetic provision. Prosthetic and orthotic services should be formally integrated into national health systems and emergency preparedness, not treated as optional or secondary services. Failure to do so risks preventable disability, loss of independence, and long-term societal costs. This presentation, presented together by a physiotherapist and a prosthetist, highlights the need for clear standards, coordinated interdisciplinary care, and sustained investment to ensure that survival is matched by functional recovery and meaningful participation in society. So as you move through today's session, I hope you take away not only practical insights, but also a sense of connection to each other and to this global effort to strengthen rehabilitation where it's needed most. Thank you for being here, and over to you, Ruba.
Thank you so much, Sandra, for the lovely introduction. Hello, everyone. Greetings from Lebanon. I am Ruba Mitre, a physiotherapist with the International Committee of the Red Cross. I will be with you today in this webinar, and we will talk about amputation in conflict. And we'll hand it to Anton to introduce himself. Thank you.
My name is Anton Johannesson. I'm a prosthetist orthotist from Sweden and representing ISPO Nordic. I'm really pleased to be here. Over to you, Ruba.
Thank you so much, Anton. So, the title of the session today is Amputation in Conflict. Amputee rehabilitation is a complex journey. Today, we will highlight the most critical aspects of amputation care in conflict setting. So let us start with the introduction. Just 1 second, in order, I'm having some tech. I will share again my screen. Okay, so everyone can see my screen?
Yes.
On this slide, we highlight the key principle of managing limb loss and rehabilitation. First, we focus on a person-centered approach rather than just the remaining limb. What does this mean? This means we treat the individual as a whole, taking into account their goals, lifestyle, and personal needs, not just the physical injury and not just the limb. Second, rehabilitation should involve interdisciplinary team approach. This team can include doctors, physiotherapists, prosthetists, psychologists, social workers, all working together to provide comprehensive care. Another important point is the continuity of care, which starts from the moment of injury and continues through prosthetic fitting and beyond. Limb loss is considered a lifelong condition, meaning individuals may require ongoing support and continuous follow-up care. It's also important to remember that anyone can be affected. Civilians of all age, from children to adults to elderly, so care must be adaptable to different life stages. Finally, we take into account the person's overall environment, including their home, community, access to services. These factors can greatly influence in a positive way the rehabilitation outcome and the quality of life. Here, we focus on amputation in conflict settings. What makes it different, amputation in conflict settings? First, there are specific challenges in a conflict, such as higher risk of infection due to the delayed treatment, the poor sanitation, the limited medical resource, the limited access to health care. Patients often also have associated injury, like polytrauma. They have fractures, burns, internal trauma, which make their condition even more complex. And also, we need to consider the non-communicable disease, such as diabetes, as well as possible additional epidemics, which can affect healing and recovery. lower limb amputations tend to occur more than upper limb amputation, especially when we are talking in a complex situation. The situation involves the blast injuries, mines. Finally, an important concept is that a well-functioned amputated limb can be better than a painful, non-functional leg. However, this idea is always difficult for a patient to accept. So overall, managing amputation in conflict requires adapting to complex injuries and challenging conditions while focusing on the best functional outcome for the patient. Now, we will move to the adapted clinical management, and we will talk about the surgery. An important principle in surgical management is life before limb and limb before lens. What does this mean? This means the priority is to save the patient's life first, then preserve the limb if possible, and only after that, the limb plans. This principle is especially relevant in conflict settings, where injuries are often severe, resources are often limited, and rapid decisions are needed to control bleeding, to prevent infection, to reduce the risk of death. The main goal is to create a well-healed residual limb that can support effective prosthetic use in a later stage. Amputation is indicated in cases such as severe ischemia, non-viable tissue, or when there is a high risk of infection and sepsis. In conflict setting, the DPC, the delayed primary closure, is commonly used. In many cases, wounds are contaminated, so they are left open for about 1 to 4 days before closure. This helps to reduce infection risk and improve the healing outcomes. In conflict settings, secondary amputation or revision surgery is an important aspect. It is often performed after the initial surgery where the conditions were difficult. Maybe in the initial surgery, we had limited time, limited resources, the contamination, we were worried about the overall health condition of the patient, and all this may not allow for an optimal level of amputation. So the aim of the revision is to improve the functional outcome for prosthetic use later on. The key idea is to preserve the most distal level possible as long as the remaining bone and soft tissue are viable. And here I have to stress on this important note that we need to have a good coverage of soft tissue, which means if the choice is between bone length or a good healthy soft tissue coverage, of course, soft tissue coverage is more important. In the early post-operative phase, a back slab is often used to maintain knee extension. In this case, we are talking about someone who has a below knee amputation. And the goal is to prevent contractures, to prevent the knee flaccum in this case. In some cases, a through knee amputation may be considered as an alternative to a transfemoral amputation. So if there is a choice between a very, very short below knee, so a through knee amputation can be considered because it can provide better weight bearing capacity and can potentially improve prosthetic control. We move on now to the medical part. Another key aspect is the rational use of antibiotics, especially in conflict settings where the risk of infection is high. Antibiotics should be used carefully to prevent and control infection without the overuse and without the misuse. as this can contribute to the development of multi-drug resistance bacteria, for example. Pain management is also very crucial in amputation. And here we have to put a goal that it's not only to treat the pain once it appears, but to do the best possible to prevent it from becoming a chronic pain. And this can be done by proper drug management, can help reduce the risk of neuropathic pain, which is a long-term complication after amputation. Also, we can help, it's important to give pain relief before mobilization and physiotherapy sessions, pain relief before change of dressing. Care for pain should also be coordinated with mental health and the psychosocial support services. Finally, peer support plays a very important role, as patients often benefit from sharing experiences with others who have gone through similar situations. On this slide, we're focusing on how daily monitoring is essential. We need to regularly check the limb for any sign of bleeding, delayed healing, or infection, a check for things like redness, swelling, usual discharge. Next, right after the surgery, a surgical compression dressing is usually applied. This helps to control swelling, protect the wound, and support the healing. After that, we move to the intermittent compression. This continues to control swelling, but also start preparing the limb for the next stage. And bandaging is another key step. It's actually used to shape the residual limb properly and prepare for fitting a prosthesis later on. We don't want to forget positioning is another key point. If the limb is kept in the wrong position for too long, it can lead to contracture. And the main common contracture that we might see for the below knee is the knee flexum. For an above knee amputation is the hip flexum, hip abductum. Finally, we can't overlook nutrition. Good nutritional support promotes wound healing, strengthens the immune system, and helps the patient recover more effectively overall. Now we move to MHPSS. People who experience amputations are not only dealing with physical trauma, but also with severe psychological stress. That's why mental health and psychosocial support is considered life-saving. Raising awareness about MHPSS is very important, particularly in conflict zone, where mental health is often overlooked. Many patients may not recognize their psychological needs. The basic psychological support should be considered as a population-wide need. In conflict settings, we have large number of people, patients, families, and even healthcare workers are exposed to trauma. It's also important to remember that both patients and responders need support, and that this type of support doesn't always require a specialist. Trained non-mental health professional can provide a basic psychological support, which is especially important in resources limited, like conflict settings, without forgetting, of course, the need for follow-up, because the emotional impact of amputation can persist or even can appear later over time. Adapted clinical management when it comes to nursing. We focus again on what was mentioned earlier, which is person-centered approach. it's important not only care for the amputated limb. Remember that these patients often have other health conditions, like, for example, ischemic heart disease or diabetes, and things gets even more complicated with diabetes. And we cannot oversee the other lower limb. We cannot oversee examining the other lower limb. In conflict settings, these conditions are poorly controlled. This is due to limited access to healthcare. So managing these comorbidities is essential for proper recovery. In this case, both the patient and the family need to be educated and need to understand about wound care, about the red flags, the signs of infection, how to manage the limb, what to expect during recovery, what's normal, what's not normal. The discharge planning, and here I'm using the word planning because this should be a plan that should be done by the interdisciplinary team, meaning doctors, nurses, P&O, physiotherapists, social workers, psychologists. This should be an interdisciplinary discharge. Finally, we need to advocate for regular referral and not just when a problem appears, especially in unstable environment where patients only seek care when complications arise, which can delay the treatment and worsen the outcome. Now for the next slide, I'll give the floor to Anton.
Thank you, Roba. I just want to repeat some of the complications that Roba mentioned. In the postoperative phase, several complications can significantly affect rehabilitation and prosthetic outcome. Delayed wound healing and prolonged immobilization can slow progress and increase the risk of further complication. Contractures, often result from inactivity, may prevent successful prosthetic fitting. Residual limb pain and phantom pain should be addressed early to avoid long-term issues. In addition, neuroma formation can reduce prosthetic tolerance. And finally, scar placement is critical. Scar in a weight-bearing areas can compromise socket fit, comfort, and function. Next, please.
Just 1 second.
Yes, sorry.
Yeah. Yes.
Next slide.
Anton, are you okay to continue?
Yes, I'm waiting for the slide.
Okay, no problem.
Roba had to restart the presentation. There it is. So I continue to common complication.
Yes.
Blast injuries are complex and challenging to treat due to the combination of injury mechanisms. Patients are often exposed to pressure waves, shrapnels, burns, and blunt trauma at the same time. In addition, internal injuries may not be immediately visible, with damage to the lungs, brain, or organs developing over time. These patients frequently present with severe polytrauma, including fractures, soft tissue loss, and traumatic amputation, requiring coordinated multidisciplinary care. The risk of infection is high, as wounds are often heavily contaminated, which can delay healing. Finally, survivors typically face long-term rehabilitation needs, including repeated surgery, prosthetic care, and psychological support. Often, the problem is not only the injury, it is the lack of coordination. Next, please. Seems to be frozen.
Yes, 1 second again. I'm having some technical difficulties.
Hi, this is the webinar administration team again. Subhash, if you have a copy of this presentation of the slides, perhaps you could take over sharing if Ruba is having some challenges.
Yes, let me share my screen if that will be easier.
Thank you very much. I've made you a co-host, Subhash.
Okay, thank you.
Okay, so I'll stop sharing from my side.
Thank you, Ruba. Don't worry, technical difficulties do happen.
Can you see the screen now?
Not yet, Subhash.
Can you see now?
Yes.
Yes, we can.
Okay.
Slide 17.
This one, right?
No, next one.
Okay.
This one, yes. Thank you. I continue with the last slide on common complications. Rehabilitation must start early, not after healing, but during healing. Poor early management can significantly compromise long-term outcomes. Incorrect positioning often leads to contracture, particularly knee flexion and hip flexion or abduction, or the combination, which can limit prosthetic fitting and function. The shape of the residual limb is also critical. Bulbous or conical forms, often due to inadequate soft tissue management, can create challenges for socket design and comfort. In addition, there is often insufficient consideration of the patient's overall condition, especially in case of multiple injuries. Patients with multiple limb loss or associated injuries, such as burn or skin graft, present additional complexity, particularly regarding skin integrity. Finally, psychosocial factors play an important role and can significantly influence rehabilitation outcome if not addressed early. This is where we start shaping the future of prosthetic user. Next slide, and over to you, Ruba.
Thank you. The adapted rehabilitation practice. Under the adapted rehabilitation practice, we mentioned the early mobilization is important to prevent complications. Positioning is a key aspect to prevent contractures. And as mentioned earlier, We mentioned that the main deformities we might face the knee flaccum, especially if we have a short stump, also the hip abductum, hip flaccum, also if we have a short stump. So we care for the position of the patient in every situation. In bed, while sitting in a wheelchair, he has to keep the knee extended, as you can see in the photo. Also, while ambulating, the patients tend to ambulate on crutches, and they flex the knee and flex the hip. It's like the resting position. So all these things should be taken into consideration to prevent contractures and deformities. As mentioned earlier, bandaging has a key role in helping to control edema and reshape the stump to prepare for the later stage, which is the prosthetic use. At the same time, we need to look at the whole person, not just at the stump. We also include pre-prosthetic fitting like basic strengthening and balance exercise. We will elaborate a bit more later on pre-prosthetic fitting in the upcoming slides. Without forgetting, of course, education for both patients and family, and education on post-fitting rehabilitation. And finally, peer support is very valuable as it helps patients feel less isolated and more motivated during the recovery phase. Next, please. What are the common challenges? In conflict setting, due to limited resources, there's often a lack of specialized expertise and a lack of proper interdisciplinary approach. This can lead to issues like poor positioning, incorrect bandaging, and not fully respecting the patient pain. We also see complications such as secondary wounds or injuries, often because conditions are not ideal. Hygiene, the wound might be infected, the patient is not ambulating independently, he might risk a fall. So we also see secondary complications. Another challenge is rushing the process. We should never rush the process, like fitting a prosthesis before the complete healing, which can, of course, negatively affect the outcome. And the basic aspect like nutrition are sometimes overlooked, even though they are essential for a good recovery. Next, please. Again, with some additional common challenges to mention. The lack of assisted devices, which makes early mobilization and independence of the patient more challenging and more difficult. We also see limited attention to the psychological status of the patient, even though trauma and emotional distress are very high in situation of conflict. Of course, daily functioning is affected as well, with difficulties in accessing basic activities of daily life, and even more complex tasks like instrumental activities of daily living. In conflict settings, patients are often discharged too early due to pressure on services. And unfortunately, follow-up is frequently off. There's an important point to make. In any even conflict situation, always take the patient's information, the patient's data. You never know when you need to refer him to a certain service that he needs. So very important, the patient's information. Another challenge is the early or inappropriate prosthetic fitting without respecting the proper timing, without doing the proper preparation, which definitely will affect the outcome. Finally, services are often uncoordinated, which makes continuity of care difficult. Next, please. Here, we're focusing on pre-prosthetic rehabilitation, which is a very important stage, and it's not an optional stage. If you want a successful outcome, it can take around 2 to 3 months for a patient to be ready. This phase starts with the correct positioning, postures, and stretching to prevent complications like contractures. We also work on strengthening exercises to prepare the body for using prostheses, along with desensitization technique to help reduce the sensitivity of the residual limb and prepare it for the prosthesis. Of course, edema control and shaping the residual limb are very important. And this is usually achieved through compression therapy. This can be done using elastic bandaging applied in a figure of 8 as shown in the picture. Pain management is also essential. And the approach in people with amputation is quite specific. It should start by properly identifying the type of pain, whether it's just a phantom limb sensation that is generally normal and often do not require treatment, or is it phantom limb pain that needs attention by taking the appropriate medication and undergoing physiotherapy, or is it the residual limb pain with underlying cause, maybe such as edema, infection, skin irritation, pressure point. So pain management is crucial. At the same time, we focus on functional independence, such as transfer and basic mobility, and improving balance to prepare the patient for walking with a prosthesis. And now, to you again, Anton.
Next slide, please. If I summarize, understanding the environment, work as a team, start rehabilitation early, and focus on function and participation. As these are just simple recommendations, there's a lot of complication behind it. But the best way to motivate someone who has lost his leg is to prepare them for the prosthetic fitting and the possibility to get a prosthesis. A well-prepared residual limb is essential for successful prosthetic fitting and long-term function. The limb should have intact and healthy skin with good sensation to allow feedback and protect against injury. It should be as much pain-free in weight-bearing area as possible, ensuring comfort during prosthetic use. Adequate range of motion, particularly in the hip and the knee, is critical to enable efficient movement. In addition, good hip extension strength and overall muscle strength are the key to achieve stability and control during gait in transfemoral, knee disarticulated, and transtibial amputees. Next slide, please. In emerging settings, the global response significantly shapes how treatment is delivered. Flexibility and ability to adapt are essential to meet rapidly changing conditions. At the same time, international guidelines must be respected to ensure safe and consistent care. It is important to maintain a continuum of care, preparing early for the prosthetic fitting phase while taking the local context and available resources into account. Finally, effective communication and coordination with all stakeholders are critical to ensure aligned effort and optimal patient outcome. Next, please. In conflict or disaster setting, it is essential to first understand the environment and adapt care accordingly. A person-centered approach should guide all intervention, taking into account not only injuries related to the event, but also pre-existing health conditions. Care must be planned based on available resources while ensuring effective communication and coordination with stakeholders. Over to you, Ruben.
We mention again how MHAPFS is absolutely vital, because amputation in conflict is not only a physical injury, but also a major psychological and social trauma. Again, a strong interdisciplinary team approach is needed for good outcomes. And lastly, we always need to consider activities of daily living, but in a way that is adapted to the patient's level of impairment and their environment, especially in conflict settings where resources and conditions can be very limited. So overall, successful care is not just about healing the limb, but also restoring function, independence, and the quality of life in a very challenging context. Thank you, everyone, for your attention.
Thank you both. What a wonderful presentation. We've got a lot of questions in the chat. Subhash, if you can unmute and take those questions, that would be great.
Yeah, thank you. Let me stop sharing. Thank you very much for a great presentation. I have some questions in the coming up, and I would like the panelists to answer. So question number one is coming from Naveen Yasin. His question is, in acute phase amputation care, wound healing and early discharge often delays technique like desensitization, bandaging, and scar management. How can we ensure timely intervention without compromising outcomes, especially in high turnover settings? Do you think, Rova, you can take this question? Rova, can you unmute yourself if you can take this question?
Yeah.
Yeah, thank you. Can I repeat?
Thank you.
Yeah, please go ahead.
Yes, thank you. The question about the wound healing. It is crucial in a complex setting. I am on mute.
Yeah, we can hear you. Go ahead.
Yes. In conflict settings, it's always, unfortunately, we have to discharge the patient as fast as possible. So we have to make sure not to make. I'm having duplication in the sound. Wait.
Is it better now? Okay. Anton, would you like to answer this question instead of Roba has an issue? Anton, can you hear? Can you unmute yourself? And
Sorry.
yeah.
in acute post-operative care, wound healing and delayed wound healing is always a challenging. And I think the main goal is what Ruba said, that if we start too early in providing with prosthesis before it fully healed, then it can damage the outcome. This depends also on what kind of prosthetic technology you are offering. If in some setting the quality of prosthesis is very low, which require a very, very strong and healthy stump to work with. So that kind of challenge is more answer to the question than the problem itself, so to speak.
Thank you very much, Anton. So he has the next question. When can we start weight bearing after stump revision or secondary amputation? And it's better to delay it to avoid any complication. So it's about weight bearing. When should we start weight bearing?
Yeah, that's very good question as well. The start of weight bearing has a positive effect to the person that is amputated, because then he suddenly can go up in the standing position and try to walk again. As I said, the psychological effects are very good, but if you start too early, you get a backlash. The patient can get pain, or the edema will affect the fitting. So I would rather train the patient without prosthesis to make them stronger and fit them when they are more prepared than go too early.
Thank you, Anton. So I have a next question, which is coming from Louis Sableban. His question is, in settings where access to rehabilitation services is severely limited or disrupted, such as in Gaza, amputees are at high risk of complications. Are there evidence-based manuals or self-guided rehabilitation guidelines that can be adopted and shared directly with amputee to support safe, independent recovery? So I'm not sure if Roba can hear us, but okay. You try to answer, Roba. If not, Anton.
I think Shuba, you have most experience on that. I don't, and I haven't seen any manual that work in that kind of settings. And that is what we are trying to do with this presentation, and the effort is to bring up this standard and having those who are in charge of this situation to allow us, because it's not only one profession, or many professions that needs to get in place to be able to help. And I am not aware of any simple solution without any resources. It's almost impossible, I'm afraid.
Okay. Yeah, I think so. I remember that I was in Gaza. At least we had ICRC pre-prosthetic manual, where we knew that how we can manage the amputee in a pre-prosthetic way. We also have some guidelines for physiotherapists on pre-prosthetics from ICRC side. So we'll be happy to share. It's also available on website of ICRC, but we can also share it to the group. Yeah. Okay. Next question is, what should the discharge criteria be for a patient with amputation to leave the hospital? I'm not sure if Roba is back and can hear us and can respond. She is working in a hospital setting. Roba? Would you try? Looks like not. She's not available. So discharge criteria for patient with amputation to leave hospital. I think this is something we need to be sure that the patient is safe to go back at least. Roba, you are back. Would you like to answer?
Yeah.
Yeah, please.
Yeah. Yes. I can hear you, but yes. Thank you. Yes.
The question is what is the discharge criteria
Yes,
for
please.
patient with amputation to leave the hospital?
Okay. Whenever we want to discharge a patient, we should always ask about his home situation, the circumstances, and based on that, we have he has to be independent on crutches. Yes, so we have to make sure that the patient is independent on the crutches, especially if he has stairs. We have to ask also if he lives on rough ground and train him to be safe on crutches. This is of course from physiotherapy wise, and if I'm giving him a wheelchair, if he's a double amputee, he has to be trained on the wheelchair, how to use it. Of course, from the nursing care wise, the family, the patient should be educated on hygiene, on wound dressing, and always take the full information of the patient prior to the discharge, in case we need to refer him, in case any complications occurred again, we should have his data.
We can, Subhas, you are muted.
Sorry. Next question is for physical rehabilitation. It's a great role for physiotherapists, such as different stretching, strengthening, balancing, weight-bearing exercise. So as a physio, how will support for phantom pain? Thanks. Question is coming from Bangladesh.
Yes.
Yeah.
Yes. Thank you. So the question is about the phantom limb. First, prior to that, we have to correctly identify the type of pain. Sometimes the patient has phantom limb sensation and not pain, which is normal and which does not require any treatment. We have to make sure that it is phantom limb pain, which means the part of the body that is amputated is causing him pain. From a physiotherapy part, we can do desensitization of the stump, and also we have the technique of the mirror therapy. The mirror therapy is mainly like a trick to the brain. We make the patient use the mirror and reflect the movement of the sound leg and do some small movements. And this is something that he should be doing constantly. So we have to educate him on that, on the mirror therapy.
Next question is anonymous. It's coming from historically in conflict setting, the disconnect between acute surgical teams and rehabilitation creates avoidable secondary disabilities. Poorly shaped residual limb and suboptimal bone lengths that make prosthetic fitting painful or mechanically impossible. Having submitted a formal treatment protocol addressing this to the ICRC in 2011, I am challenging the panel, why is PNO still treated as reactive supply chain function months later rather than preoperative clinical necessity. Specifically, are your organization implementing formal CPO surgical consultation or immediate post-operative processes to optimize functional outcome and prevent surgical revision? Anton, you would like to take? Yeah.
This is the webinar administration team. That may be one that we want to take offline and respond to the individual separately. I don't know if you have any thoughts on this.
Yeah, I think so. That's that's definitely okay. Next question is coming from Ines. What are your recommendations to improve the continuity of care and amputee rehabilitation quality in conflict-affected region? Roba, could you answer this?
Yes, thank you. So the question is about continuity of care. As mentioned that amputation rehabilitation is a process. Okay, so the physiotherapists they have a role in pre-fitting, post-fitting. The mental health also they have a role. The P&O, the nursing team. So it is an interdisciplinary team approach, as we mentioned earlier. The care for amputee does not stop when the patient leaves the hospital. This is why the referral is the key, and the patient has to know that he needs pre-fitting. He cannot come after 1 month or 2 months to the P&O asking for a prosthesis without having done the pre-prosthetic fitting. So referral, we have to educate the patient that he needs pre-prosthetic rehabilitation, refer him to a rehabilitation center. He has to be followed by MHPSS, followed by P&O until we reach the prosthetic use. And it does not stop here. We also can go also a step further, which is social inclusion. We can see what type of activities can we refer him to social inclusion activities, to engage him in the society, to engage him again in the sports, and so he can become independent and active.
Thank you. Next question is, how can we better apply person-centered care in low-resource setting? Anton, you want to answer that?
I think Ruba is better in answering that question.
Okay.
Sorry.
Okay. Now with that, we can. Okay, low resource setting. I just wanted to ask Ruba if she can answer. How can we maintain the patient-centric approach in low resource setting?
Yes, thank you. It is always challenging in low resource setting and in a conflict setting to. Yes,
Yeah, go ahead.
Yes, the low resource setting.
Yeah, I mean, how to maintain the patient-centric approach? Yeah.
I just 1 second, because the sound is coming back. Just 1 second. The sound is coming.
Meanwhile, I maybe I can answer this question while Ruba is facing the issue. So the patient-centric approach, definitely we can maintain in the low resource setting as well. All what we need to do is normally it is important that we go through interdisciplinary team approach if it is possible. If you have different professionals available. I think we need to interact with each other and take help of each other and coordinate with each other. Then it's quite possible to work on a patient, and specifically we need to ensure that the person is following through continuum of care. Like once he has got injury, he has hospital treatment, then we have to ensure that he has is well linked or referred to the prosthetics center where he can get a pre-prosthetic management and also proper treatment. So with that, I think we will invite some of the people directly putting hands. So I'll invite Sahar Yar Khan. Could you ask your question, unmute yourself and ask your question directly to the panelists?
Subhash, apologies, this is the webinar administration team again. We've actually disabled that function for participants, so you are going to have to read their questions out, I'm afraid.
Okay. Fine. We will go back to the questions. Sorry. Okay. Next question we have is 1 second. I found some. I'm not able to open question answer now.
That's okay. Subhash,
Sorry.
I'll take over just for a second.
Yeah, please.
No
please.
worries.
Thank you.
Anton, there is one question in conflict-related amputations. When do you start prosthetic measurement and fitting? And how do you balance early rehab with stump readiness?
There are not only one factor. There are multiple factors. It's the healing process, how it's going. It's the control of the edema. It is the access to pre-prosthetic care, and all this needs to be in place before you start taking any measuring or cast of a patient. Otherwise, you are just wasting your time because the patient will get up and walk, and the volume will change very rapidly after. So it's complicated, but during the first year, it's the critical part when you are when the most of the volume changes will take part. And at the same time, I'd like just to emphasize on that the amputation requires sustainability in service. It's nothing that we come and do. It's something that needs a sustainable in services to meet these challenges for the amputee, both regarding volume changes, which is also a part of the higher activity. And these patients are often young, between 10 and 30, 40 years old. So they have many years ahead of themselves. So that is what I like to emphasize on, is sustainability in service.
Yes, very, very important. While you're on there, another quick question about a young diabetic patient with BK amputation. What are the key rehab challenges, and how would you prioritize interventions? And that could be if Rupa is also available to add to the rehab part of it. But let's talk a little bit prosthetically, Anton, while you're still unmuted, about the young diabetic patient with the BK amputation, some of the challenges and how you would prioritize intervention.
So maybe I will take the part of the rehabilitation. So for me, the important is to focus on the other lower limb prior to focusing on the amputated stump. The other lower limb has to be healthy, has to be checked. The sensation, there's no neuropathy, there's no wounds, because mainly it's important to protect the lower limb that is left. And it has to be clear to the patient that the prosthetic that we are giving is for his independence, for his safety, to also reduce pressure from the other leg. He has to know his limitation when it comes to prosthetic use, and always encourage the patient to follow up with medical care to see if he's regularly taking his medications. And one of the most important things also to check the vision, and this might qualify him whether he can wear a prosthetic or not. If he has a very low vision, is he gonna be safe or not? So it's not, when it comes to diabetes, it's definitely not about the limb as much as his overall health condition, protecting the other lower limb. And I don't know if Anton would like to add anything further regarding this question.
No, and as I mentioned before, it's complicated, and you have to take care of both of the limb. And the remaining limb is very important. And one way to relieve that leg is making a prosthesis, so you can equal the load. But it's challenging, and if we don't have the medication, then we are in trouble as well. So basic medication is needed, and as you mentioned, Roba, education of the patient and the family, how to take care of it.
Thank you both. And another question just related to weight bearing. During the presentation, it was mentioned that weight bearing too early may hamper the patient outcome. Is there any criteria from when we can proceed to weight bearing on the amputated limb?
If I may answer that.
Sure, go ahead.
It has a lot to do with what kind of prosthetic technology you have access to. And if you have a total surface bearing prosthetic system, you are actually able to weight bear on certain small wounds. And the benefit is that you get a better blood circulation in the residual limb when the patient is walking, and that can enhance the healing. But if you don't have that kind of prosthesis, you can jeopardize the healing part as well. So that's the balance that every prosthetist has to decide on.
Mm-hmm. Rupa, do you want to add anything to that? Or there's another one actually directly related to a physiotherapist who's working in a UN level hospital. How can I best contribute early in the amputation care pathway to improve functional outcomes even before the patient reaches the rehabilitation phase?
Yes. So as mentioned, the pre-prosthetic rehabilitation is not something that is optional. This is something that a patient should go through in order to, at the end, receive a good outcome when it comes to prosthetic wearing. So positioning, prevent deformities in the lower limb, control the edema. The patient has to ambulate as fast as possible to be independent. He has to be educated on his exercises, the strengthening exercises, the stretching exercises. If he's using a wheelchair, the transfer on the wheelchair. So all of these are crucial and essential as the physiotherapy. But also, we should not limit the care on the limb. He has to strengthen the upper limb. He has any amputee should have a very good upper limb strength. The trunk also, you should have a good trunk in order to compensate and a good balance. So no step can be missed. Always ask about the pain, because the pain can be a limitation for the rehabilitation. The pain can be a limitation for the prosthetic later on, and ask the correct questions about the pain, whether it's a phantom sensation, it's a phantom limb pain, in order to refer or to start desensitization and mirror therapy.
Perfect. You just touched on a couple of other questions. There's quite a few, but there's a lot of repetitive questions on mirror therapy, etc. It sounds like we need a course just on mirror therapy. But really quickly, I think we want to wrap up now. And so just wondering, one question about progressing an amputee patient from frames to crutches towards a prosthesis. If you could, just talk about that procedure, please.
Yes, thank you. So for me, if I have a young patient, he should be able to use the crutches. Will not use a walking frame for a young patient. And more specifically, if I want to choose what type of crutches, I will go for the elbow crutches. Because the long-term use for auxiliary crutches might later on make some compression and cause some pain in the upper limb. So for a young patient, always use the elbow crutches. Of course, for someone who does not have a good balance, maybe he is polytrauma, a young patient with polytrauma. So the balance will tell us. If he does not have a good balance, we might start with the walking frame and try progressively to switch to crutches. Because if he's discharged home and he have stairs, it will be difficult with the walker. He has to be trained on the crutches.
Absolutely. That's fantastic. I want to turn it over to Pete just to do any final remarks if he would like. Just before I do, I'd like to just thank the speakers. Fantastic presentations. Thanks, Subhash, for managing some of the chats. I really appreciate that. And to each and every one of you on this call, there was 250 I saw at one moment in time from all over the world. So we just want to say a big thank you. We are available as a resource. Please connect with us if there are any other questions, etc. And I'm going to end off on that and turn it over to Pete. Thank you, everyone.
Thank you so much, Sandra. Thank you to all ISPO colleagues for a wonderful session. I think a huge amount of detail as well in the questions, which shows how much people are interested in the topic, which is brilliant. Thank you also to World Physiotherapy for hosting and all the support behind the scenes, especially as I know it's a public holiday in the UK where most of you are based today. So very much appreciated again. And thank you to the interpreters who are volunteering and doing an amazing job in keeping this moving forwards. Great session. Next week, we have the topic of burns, which is incredibly important in emergencies. I think we see, particularly in conflict settings, and many of the patients, even those with amputations and other injuries, that have burns as well as a consequence of blast injury. So a really, really important topic, and we're supported then by Interburns, who will be managing the session next week. So thank you again to all of you for attending. Thank you to ISPO. Thank you to everybody behind the scenes that is supporting, and we see you next week. Thank you very much. Bye-bye.
Bye-bye.